Center in Israel. Our patient is a 31 years old male who presented with the right eye blurring vision, including vision loss in his right eye's central field for 2 days. The patient had non-specific pain in his right eye. He denied having fever, headache, rheumatology disease, night sweats, genital or mouth ulcers, any contact with animals such as sheep or cat, visiting caves, traveling abroad recently. Past medical history, no illness, no medication, no allergies. In 2006, he was involved in a car accident and suffered multiple fractures in the skull. Past eye history, myopia -5 diopters. Family history, grandfather had retinal detachment. Eye exam, visual acuity, cone glasses. In his right eye was 645 and in his left eye 7.5. RAPD was negative, color vision in his right eye was 3 out of 7, light saturation in his right eye 30%, confrontation visual fields, right eye scotoma, intraocular pressure in both eyes was 15, anterior segment, both eyes normal, fundus exam. As you can see in the fundus picture of the right eye, the optic disc is well defined and slightly tilted. There is macular elevation 1.5 disc area in size with central yellow lesion involving the fovea, apparently with retinal hemorrhage, which is highly suggestive of CNV, choroidal neovascularization. In the left eye, we can see a standard fundus with no findings. In conclusion, 31 years old male who presented with right eye central scotoma, macular lesion, and no evidence of nerve damage or any pain. There are several differential diagnoses. The first one, chorioretinitis. However, the anamnesis and eye exam don't fit. The second one is Best disease. His presentation includes only one eye. He has no family history and no further peripheral lesions. Myopic CNV is a definite option. However, his myopia is only -5 diopter, while myopic degeneration definition includes axial length longer than 26.5 millimeter and myopia greater than -6 diopter. The last option is Pachychoroid disease and presentation of CNV secondary to CSR. To help us determine which is the appropriate diagnosis, we perform the following test in our retinal clinic. Autofluorescence to rule out best or bilateral involvement, OCT plus OCT enhanced depth imaging to get better choroidal observation, and fluorescence angiography to confirm that he truly has CNV. As you can see in his right eye autofluorescence picture, there is a macular lesion with an hypoautofluorescence area and in the center, which is surrounded by hyperautofluorescence ring. His right eye OCT scan displays a central macular thickness of 656 micron compared to 259 in his left eye. Moreover, there is an elevation of the foveal contour with central hyperreflective area surrounded by subretinal fluid. There are small intraretinal cysts. In the external layers, there is a lack of continuity in Bruch's membrane with inverse PED, pigmented epithelial detachment. His OCT EDI allowed us to measure his choroid thickness accurately, which came to 357 micron. On the FA, on the fluorescence angiography test, we can see a central hypofluorescence that becomes hyperfluorescence and grows in area and intensity, while the surrounding ring is well-defined and grows only in intensity. As my colleague mentioned in the previous lecture, several clinical manifestations have been described to reside within the Pachychoroid disease spectrum. The first 4 manifestations were presented in the same patient previously. Let's take a few seconds and try to compare between our patient presentation and the clinical manifestation that I just described. Probably, all of you answered right. Our patient diagnosis is focal choroidal excavation. FCE, focal choroidal excavation, is characterized by localized area of choroidal excavation without evidence of posterior staphyloma or scleral ectasia. Most patients with FCE have been diagnosed in their 4th to 5th decade. No gender predilection has been found. Most cases described have moderate myopia. Patients tend to be asymptomatic or report blurring of vision or metamorphopsia. OCT is the preferred diagnostic imaging modality. Two patterns of excavation have been described, conforming type and non-conforming type. In the conforming type, the photoreceptor tips are not separated from the underlying RPE, whereas in the non-conforming type, hyperreflective space can be observed between the photoreceptor tips and RPE, as you can see in the right picture. Moreover, an unusual hyperreflective choroidal tissue, indicated by white arrow in the picture, as you can see here and here, can be seen to bridge the space between the bottom of the excavation and the outer choroidal boundary. FCE was detected in 2 to approximately 8% of patients with central serous chorioretinopathy. The etiology is unknown, and the treatment when there is an evidence of CNV is anti-VEGF. So let's go back to our patient. In the day after his admission to ER, he was treated with a single intraocular injection of Avastin. As you can see in the OCT 1 month later, the central macular thickness is 293 micron compared to 670 during his admission. There is shrinkage in the hyperreflective lesion and disappearance of intraretinal cyst and subretinal fluid. Unfortunately, although he experienced a significant improvement in his retina condition, his visual acuity didn't improve so well. Thank you very much all.